right, let's finish our assessment of our normal newborn. We're going to flip them over and check out their back. One of the things that we see frequently in our newborns is what we call a stork bite. It's this redness that you see right here. This is a common place for it, but we actually see it any place where there was pressure while baby was in utero. This is going to clear up and go away on its own. It doesn't require treatment. It usually just requires reassurance of the parents. Mongolian spots, more common in darker skinned babies, usually on their buttocks like we see right here. However, it can be all over. So here's some more on this baby's back. This baby has more, not as big and dark as this, but certainly more widespread. And they can be on the arms and legs. I want to document the size and the location. And how do we tell the difference between a Mongolian spot and a bruise is that our bruises don't blanch. Our spine, we want to check and make sure that it's intact and that it's straight. Check for a tuft of hair. We're going to look for deep dimples or pilonidal sinuses along the spinal tract. We're going to do truncal incurvation reflex. That's where we kind of support the baby where they're not really supporting their legs on the bed. We've kind of got them suspended, but we're supporting them and holding their head and neck so they're not bouncing around. And we're going to stroke down along one side of their spinal column, and their body should curve toward that side. We talked in the last session about how we're going to look at the gluteal folds and make sure those are lined up appropriately. Then we're going to do constitutional measurements as part of our assessment for this newborn. And we have a weight category. I'm going to talk about that a little bit more in a minute. Then we have our length and our weight. And so we determine if this baby is large for gestational age, appropriate for gestational age, or average for gestational age, and then small for gestational age. And I want to talk about that a little bit more on this next slide. Part of our assessment for this baby is we're going to do a head circumference, chest circumference, and abdominal circumference. The head circumference should be larger, chest a little bit smaller, abdomen even smaller. And if it doesn't go in that declining order, then it warrants further investigation. It's normal for our babies to lose 5 to 10% of their birth weight in those first few days after birth, but they should be gaining that back and might even exceed their birth weight by about 10 days or so. So here's our gestational age chart that hopefully you filled out every clinical for your babies in L&D, in antepartum, postpartum nursery. And we know that any baby that's above this line, above the 90th percentile, we're going to call large for gestational age. Anything between the 90th and the 10th percentile is appropriate for gestational age. And then anything below the 10th percentile is small for gestational age. So this is based on gestation and weight. And we're just seeing what pool they fall into. When we talk about our weight categories, such as normal weight, low birth weight, very low birth weight, and then extremely low birth weight, that's just a set point. It has nothing to do with gestational age. This one, we're going to go the weeks of gestation. We're going to go up to whatever their weight is, put a little dot on here. Because it's above this 90th percentile, that baby's going to be a large for gestational age. Over here, we talk about a normal birth weight is 2,500 grams. All right, if this baby is actually term, then this baby is going to be at 2,500 grams. This baby is going to be average for gestational age. But let's look right over here. This 2,500 gram infant, if they're only 32 weeks, yes, they're normal weight, but because of their gestational age and that weight, they're large for gestational age. Make this a little bit clearer. Let's look at this 1,500 grams. So here's our 1,500 grams. That's considered low birth weight. But that 1,500 grams, if they're 25 weeks along, that's low birth weight, but that's actually a large for gestational age kiddo. And when this becomes even more important, let's look at this 1,000 grams. So here's our 1,000 grams. If our baby is 24 weeks old and weighs 1,000 grams, we say that's very low birth weight. Or at 25 weeks gestation, he's an average for gestational age. So for gestational age, it's average, but the classification of a very low birth weight infant means that he's at higher risk than the babies that fall in this category. Or extremely low birth weight, less than 1,000 grams. Let's look right here. This baby who is born at 24 weeks at less than 1,000 grams, if he's born right here at 750 at 24 weeks, again, he's in the average for gestational age category for gestational age, but that extremely low birth weight means he's at very high risk for survival or lack of survival. It makes sense because we know this is right at the age of viability. So not only is his weight a factor because he's extremely low birth weight, puts him at a risk category, so does the 24-week gestation. Even though on the AGA, SGA, and LGA scale, he falls in average. It doesn't mean that he doesn't have risks. Pain in our NICUs, they have a high-pitched squeal. Sometimes we can tell just because of how distorted and their face looks that they must be uncomfortable. The flexion and abduction of their limbs, they're just kind of moving around frantically, pulling their legs up and down and, kind of fighting with their hands. They're just kind of writhing in their crib. And then we actually see changes in their vital signs. And we can treat pain with pain medicine, but we can also do a lot to treat them with non-pharmacologic management, such as swaddling, non-nutritive sucking, sucrose, and skin-to-skin with mom. When we do our circumcisions, we do a penile block to numb their penis, but we also give them 24% sucrose solution and their binky and let them suck with all that sugar, and it actually does calm them down, and they have shown in research that that actually stabilizes blood pressure, pulses, and respirations. Our gestational age assessment, this is important because it helps predict who may and may not survive. It's accurate to within about 1 week of gestation. So if a mom comes in and has a baby, she didn't know she was pregnant, comes in and delivers, we can look at our gestational age assessment and determine that maybe this baby's 23 weeks along. And that's going to help drive some of our conversations with our parents about how much we really want to do to help this baby survive. If we know that this is a 21-weeker, then it doesn't make sense to do all the resuscitations when we know those babies don't have a chance of survival. But then if we know that this is a 24, 25-weeker, we do know there's a chance of survival. And so that gives us a starting point to have those conversations with our parents. The closer to the time of delivery that the gestational assessment is done, the more accurate it is, up until about 96 hours. After 96 hours, our babies do post-delivery maturation, so it's not as accurate as it would have been if it had been done earlier. Our gestational age assessment, we look at our neuromuscular maturity, all these different angles and square window and the posture, all that is judging how mature those muscles are. It's looking at the resistance at those joints. The more preterm they are, the laxer those joints are going to be. The more we're going to be able to position them in any position we want. The more mature, the older gestationally this infant is, the more resistant their muscle and their joints are going to be to moving them in these different angles. We look at their physical maturity, their skin, like we talked about. This is the exact same picture from earlier, that lanugo, looking at their plantar creases. Is their skin thin or is it thick? And like we talked about that dry skin that we showed pictures of in the last assessment. The older they are, the drier their skin's going to look. The younger they are gestationally, the thinner and almost see-through their skin is. Those 23, 24 weekers, it really looks like their skin's almost transparent. We're going to look at the size of their little breast buds. Looking at their eyes, are their eyes fused? Do their ears recoil when you fold them down? We're going to look at their genitals, male and female, and they have different appearances at those different gestational ages. Some of the reasons we do this is because not all of our moms know they're pregnant. We've had a mom that came in, she went to one of the hospitals that didn't even do OB. She went to the ER because she was having such severe belly pains, and she actually delivered in the car before she got into the emergency room. And when they got the baby transferred to a hospital that could take care of them, they determined by gestational age assessment that this baby was 30 or 26 weeks along. So we do it so it can help drive some of our decision making. It helps us determine types of medication, types of resuscitation equipment that we can use. It's going to determine the different type of drugs and how those are going to be utilized by this little tiny baby's body. And it helps us in determining getting this baby ready for discharge. We know any of our babies that are born at less than 37 weeks, they have to have a car seat test before they're discharged, which means that they have to be able to sit in the car seat that they're going to go home in for 90 minutes while they're on the monitor without any apnea or bradycardia. If they don't pass that, if they have one episode of apnea or bradycardia in that 90 minutes while they're sitting in that car seat, then they have failed that. They're not going to go home. Some of our babies, we know they're probably going to have to go home on oxygen because of the age they were when they were delivered. Thermoregulation is a big thing with our babies. We've got to keep them warm. We said that in the first part of this lecture. The blood vessels are closer to the skin. They have less adipose, so that blood is running very close to the surface, so it's easy for them to get cooled off. They have a large body surface area. They have more skin exposed than what they have core to help keep them warm. And our babies cannot shiver. If you and I get cold, we're going to shiver. It increases muscle tension and muscle activity to increase our metabolism to warm us back up. Our babies can't do that. So they have non-shivering thermogenesis by metabolism of brown fat. And babies are the only ones that have this brown fat, and it's there primarily to help keep them warm. But once that brown fat is metabolized, they have to have good oxygen in order to metabolize that brown fat. But once that brown fat is gone, those babies don't have a backup way to help keep themselves warm. When we're talking about our baby's head compared to his body, our baby's head is 25% of his total body mass compared to being only 6% in an adult. So that's why putting a cap on them, getting their hair and head dry and putting that cap on them is so vital in keeping them warm. That's why we want them to wear those little hats and those little blankets over their head when it's cold outside so that they don't lose too much heat. But they can lose too much heat while they're in our hospitals because of our air conditioning, our fans moving air across our babies. You need to know the different ways that babies lose heat and what you can do to prevent them. We talked a little bit about this morning on the earlier part of this lecture when we were talking about that we have to get our babies warm and dry. This is the effect of cold stress. Cold stress is when we allow that baby to get cool and their core temperature starts to drop. We said it increases O2 consumption, so it's going to increase the respiratory rate. Because of this low O2, because they've gotten cold, it causes pulmonary vasoconstriction. Therefore, blood is shunted away from the lungs. If the blood is shunted away from the lungs, it means we have decreased O2 going to our tissues. When we increase our respiratory rate and our O2 levels drop, we have peripheral vasoconstriction. So now we have two places that we are being constricted, so we're not getting good O2 and good blood flow to our tissues in our body. That's going to drop the PO2, drop the pH. It's going to increase anaerobic glycolysis. That's going to increase more vasoconstriction, more peripheral constriction, more shunting of the blood away from the lungs. It's going to increase the circulation of deoxygenated blood, going to increase our lactic acid. It's going to increase our vasoconstriction in our periphery, which increases our pulmonary vasoconstriction, which further. This is a big vicious cycle because we allowed this baby to get cold. This baby gets cold in our hospital rooms that are 70 degrees. So we have to warm our babies. Warming our babies and drying our babies has got to come before we worry about their O2. And I know that you've learned forever and ever and ever ABC, ABC, ABC. Our ABCs will not work if they are so vasoconstricted, so pulmonary constricted, that they're not able to circulate the oxygen that we do give them. So you have to warm them, you have to dry them, you have to prevent them getting cold. Then you can deal with their airway. And I've had this discussion with students multiple times. They always want to say, but you've got to do your ABCs. There are times that ABCs do not take the priority. And one of the things I want you to think about is if you have a victim down and they are connected to an electrical something and they are being electrocuted, you do not run in and do ABCs. There is something else that takes priority. You have to get rid of the electricity or you're going to have two victims, you and them. If you have a person at the bottom of a pool, you are not jumping in the pool and you are not going to do CPR at the bottom of that pool. You have got to get them up out of the water before you can do that. Please think about that when we're thinking about our ABCs for our babies. We have got to get them warm and dry. And that this vicious cycle starts because we don't dry them and keep them warm in our hospitals at 70 degrees. Our babies can have hypoglycemia. Some of the risk factors for hypoglycemia are being an infant of a diabetic mom, being a large for gestational age or being greater than 400 grams, having preterm birth. Small for gestational age are these low birth weight, very low birth weight. If they're post-term with evidence of muscle wasting, and then any exposure to stresses, the hypoxia in utero, cold stress once they're out here, exposure, they've got sepsis, their bodies are working so hard they utilize all their glucose and they drop their glucose. Our infant of a diabetic mom, the glucose comes across to the baby. Baby doesn't have a glucose problem, so they kick up their insulin to deal with all that sugar coming across from mom. As soon as that cord is clamped, their sugar load stops, but their insulin level is still really, really high. So they use up all the glucose that they had, they're not getting any new, and they become hypoglycemic within about an hour of delivery. The same thing happens with our large for gestational age babies. They tend to have higher insulin levels because of this increased food source that's been coming across from the placenta. Our preterm babies, probably because they're low birth weight, they don't have a lot of that adipose tissue. They're stressed. We talked about the stress increasing the risk of hypoglycemia. The fact that they're preterm means that they're under stress. They may be hypoxic. The smaller they are, the harder it is going to be to maintain their temperature, so they're going to have some cold stress. The more preterm they are, the more at risk they are for infection. So this leads to all this down here. Then our post-term babies with evidence of wasting. The reason they look wasting is because they have not been getting good nutrition across from that placenta. If they're post-term, that placenta may not have been working well. And that's why they have evidence of wasting. Therefore, they have nothing in reserve. So the minute they use up whatever they're circulating, they don't have anything, they don't have any fat anywhere that they can turn into some glucose for them. Symptoms, very jittery, very, very lethargic. If they go from having this good, nice, tight muscle tone that we talked about to this real floppy tone, that's either that they're hypoxic or that they're hypoglycemic. We consider a baby hypoglycemic if their blood sugars are less than 40 milligrams per deciliter on like a heel stick. We'll do heel sticks in the nursery, and if those heel sticks are less than 40, then they tend to have to get a serum level and send that down to the laboratory. Our babies that are at risk are very low birth weight babies or are babies who are large for gestational age, they're going to be on a glucose testing protocol. And every hospital has one that's just a little bit different. If you're large for gestational age or you're an infant of a diabetic mom, some of our hospitals say you are going to get glucoses before you eat and 2 hours after you eat for the first 24 hours. Other hospitals say you're going to get 2 or 3 of those sticks an hour apart, and if 2 or more of those have been normal, then we can stop doing that. We're going to warm their heel before we stick them. Remember that acrocyanosis, we know they have sluggish circulation. They have neonatal foot warmers. They're little gel packs that you break. They're nice and warm. We tape it on their foot. A lot of times we'll wrap their foot up with a blanket or wrap a diaper around it to keep the heat in around their foot. Wrap them back up for about 10 minutes or so that we increase the circulation as much as possible. And then we do a heel stick. And we need to go outside of where these blue lines are on their heel to stick them. We do not want to be here in the middle because that's where one of the big nerves run, and we don't want to cause any nerve damage. Some people say that if you put your thumb right here on the bottom part of their foot, then you can go to either side of where your thumb is. And then we want to make sure these babies get fed early, or large for gestational age babies, if that's appropriate. And we'll talk about there are certain babies we do not want to feed because of how sick we think they are. We'll talk about that when we talk about our NICU babies. Our routine care, we used to, oh my goodness, we had to have those babies bathed within 10 minutes of delivery. And now we're finding out that's probably not been the safest thing and not in the baby's best interest. So some of our hospitals are going toward, and there's research to back this up, that we don't bathe our babies for the first 24 hours. Their skin is really immature. We don't allow them to get some of that skin thickening because we bathe them so early, and we could set them up for some infections. We know that in the absence of a known maternal infection, there is no harm in not bathing that baby. Ooh, what about all that blood? Where do you think that baby's been for the last 9 months? What about that vernix? That vernix has been on that baby since very early in the gestation. It's not going to harm this baby. Our cord care, all we do for cord care is make sure that the diaper is below the cord until the cord falls off. No tub baths other than this initial bathing that we do. Once we do that initial bath, that we might get that cord kind of wet when we're doing that. They are not supposed to have tub baths until that cord falls off. We need to encourage bonding, skin to skin, early breastfeeding, early and frequent interactions between mom and baby. We used to rush those babies off to the nursery as fast as we could after delivery, and then we wouldn't give the baby back to mom for 4 or 5 hours. That's not in mom or baby's best interest. Leaving baby with mom, letting them do skin to skin. Helps mom, helps her uterus clamp back down, helps that breast milk come in. It helps stabilize the baby's temperature, his respiratory status. It's better for both of them to keep them together. And then get them feeding as early as is safe for both mom and baby. There's nothing that says we have to wait any after baby is delivered. If this is a normal, healthy newborn, they can breastfeed immediately afterwards. And then do our parent and family education. We need to include whoever's going to be around that baby the most, mom and dad, mom and significant other, mom and grandma, whoever's going to be around, we need to include them. We need to talk about safe sleeping positions. We need to teach them about cord care. We need to show them reflexes and introduce them to their baby. We do screening tests. All babies are required to have a hearing screen before discharge from the hospital. And this is a picture of just one of the types of hearing screens that we do. They have a little electrode here, and then they have a couple other electrodes placed, and then they have this little tiny little thing put in their ear. They sleep through this. They do not have to be active participants. In fact, if they're awake and crying, they can't do this. They can't do it while they're awake and fussing. We do a newborn metabolic screening. A lot of people call that the PKU. And PKU is only one of the tests that they test for. They do these 5 little circles. It's a blotter paper. It's all filled out. We have to fill those circles up, make sure it soaks all the way through so that it looks, all those circles are completely filled on the back side of this as well. And then we send that off to the state lab. Texas has one of the most robust infant screening protocols in the nation. There are some states that do less than half the number of newborn screens that Texas does. I think Texas right now is up to 35. So PKU is only one of them. And every state's probably going to test for PKU and congenital hypothyroidism, congenital adrenal hypoplasia, cystic fibrosis, sickle cell, and then whatever that state has agreed to. And the reasons we do these is because these are typically inborn errors of metabolism. That's why it's a newborn metabolic screen. With this screening, we can determine that this baby has an issue before the damage is done. Look at that face. I just think that's just too precious of a picture. I found that when I was looking for hearing screen. I had to put it in here. All right, our newborn screening, like I said, state mandated. Every state does a little bit different. It's testing for those metabolic disorders. The requirements for the newborn screening are that the baby has to be at least 24 hours to 48 hours of life, that HOL, hours of life. And then we repeat it again at about day 10 days of life. They have to have had formula or breast milk for about 24 hours before we can test. So our babies who are sick, who have delayed breastfeeding or bottle feeding, our babies in our NICU that aren't old enough to be able to tolerate anything in their GI system, we can't do newborn screening on them because the screening is testing that these metabolites are building up in the baby's blood. We test, we find that out so that we can put them on medication or adjust their diet before everything that builds up in their body tissue damages their organs. Congenital hypothyroidism causes mental retardation, and we wouldn't know that until they're much, much older. But if we know that and we test them in these early days right after delivery, after they've had 24 hours worth of something in their stomach, breast milk or formula, then we can put them on thyroid medication and prevent the mental retardation. And that's all I have to say about that. This is it for our normal newborn assessment. Have a great day.